In this first introductory lecture to rheumatology, I want to take you through an approach to joint pain, teach you how to interpret an arthrocentesis, and then kind of get a preview of antibodies. Throughout this entire section, you have to remember that rheumatology is about inflammation, often presenting as joint pain. But there is no confirmatory test for a lot of these diseases. It's more a clinical syndrome that you have to put together, including joint fluid aspiration and systemic symptoms. So let's start off by walking you through an approach to joint pain, which is much simpler than the one in the intern content, but is good enough to get you started in rheumatology. If you want more details, check out the intern content, Approach to Joint Pain. So a lot of rheumatology is going to begin with joint pain. And the first thing you have to ask is the timing and toxicity. If the disease is acute, that is, they come in very toxic, the list is pretty short, and a toxic presentation is going to be red, hot, swollen, tender, febrile, loss of function. They're going to present to you in the hospital. They go from, I was fine yesterday, to now I cannot move my knee. Patients notice this. And what you're looking at is trauma, infection, crystals, and reactive. And reactive, I mean you can have gonorrhea literally in the joint, or you could have gonorrhea in your body and it just happens to look like an infected joint. Loss of function, very few diagnoses you need to consider. But if the timing and toxicity is more indolent, and it's chronic. This is harder because there's more things to consider. And first you're going to consider, is it inflammatory? Yeah, their joints hurt, but is it even red, hot, swollen, and tender? Because if the answer is no, it's probably just osteoarthritis. And this is supported by someone who's obese, who has pain in the joints that they use a lot, and they have no signs of inflammation, no fever, no ESR, no CRP. But if there is inflammation of any kind, then you're left with an inflammatory joint. And you say, okay, well, this is inflammatory. How many joints are involved? Knowing that any of the diseases in the inflammatory category can present with a flare, and a flare may be an acute single joint. Knowing that these indolent diseases can flare and appear toxic at one point or another. Just keep in mind, if you follow this tree, you'll help keep the diseases straight in your head. So if there's one joint involved, it's generally the more toxic diseases, or it's a flare of the chronic multi-joint disease. If there's more than one, then you're in the rheumatologic section, right? This is what we're going to talk about in the next series of lectures. And the things you really want to consider are going to be lupus, rheumatoid arthritis. These are seropositive because they have serologies. The seronegatives, the spondyloarthropathies, and then other connective tissue disorders. And that's annoying, right? Because that's like all of rheumatology. But this is to remind you that the diseases that are going to present with joint pain are either going to be on a short list, crystal disease, infective disease, monoarticular arthropathies, seronegative spondyloarthropathies, or the seropositives, lupus or RA, or osteo. But don't forget that other connective tissue disorders exist and that they might have joint pain, but also realize that these other connective tissue disorders are going to present with inflammation of other organs beyond just the joints. So they need to be considered, but they're more on the long list. Again, short list, check out the intern content for more info on approach to joint pain if you want to have a more robust approach. But if you ever see a red, hot, swollen, tender joint, there is only one right answer. It is always going to be arthrocentesis. You may not see the arthrocentesis be done in practice. Someone comes in with gout, they look like they've got gout, you treat them for gout. But if someone comes in undiagnosed, red, hot, swollen, tender joint, you put a needle into it, you suck it out, and you look at it to figure out what's going on in the joint. Red, hot, swollen, tender joint, arthrocentesis, aspirate, and take a look. So, of course, you need to know how to interpret an arthrocentesis. What we're going to do is look at the fluid based on its overall appearance, how many white blood cells there are, how many of them are neutrophils, polys, what the gram stain shows, and with the gram stain you always get a culture, whether or not there are crystals, and we'll link that to the disease state. And there are 4 categories that I want you to be able to lump all disease into. Once you put a needle into someone's joint and suck it out and take a look at it, you should be able to say it is one of these 4 things. That is normal. Oops, shouldn't have tapped that. Osteoarthritis. Septic, way over here on the right. And in between osteoarthritis and septic is inflammatory. All right, so you can tap a normal joint. It's hard because there's not a lot of fluid there to go after, but if you've got a steady hand and you know where you're going, you can tap someone's normal joint and suck out some fluid. And if you did that, what you'd see is serous fluid. You can see right through it. There's going to be less than 200 white blood cells. Very, very small amount, and very few of those are going to be polys. Gram stain is negative and crystals are negative, of course, because it's a normal joint. Probably should not have tapped that person. You could have, but probably should not have. So if someone comes in with a red, hot, swollen, tender joint, it can be osteoarthritis. You probably will get the history of osteoarthritis based on the x-ray and history. Look for the obese person who has joints that are hurting in the large weight-bearing joints and ones they use a lot. But if it's red, hot, swollen, and tender, even if you think it's osteoarthritis, on the test, the answer is to do arthrocentesis. And what you'll see is basically a normal tap. It'll be serous. You have a little bit more white cells, less than 2,000, but as you'll experience, way, not even near the range of inflammatory or septic, and it's still 25% polys, no organisms, no crystals. Let's take a trip over to the other side, because once you see the full spectrum, it's easy to identify inflammatory. If you have a septic joint, you will pull out pus. It is opaque and it is white. There are a truck ton of cells. We're talking greater than 50,000. 50,000 is the number. If there are more than 50,000 white cells on your tap, it is septic. No matter what else you find, it's septic. In life, that may not be true, but 50,000, greater than 50,000, septic joint, done. The culture is probably going to be positive, and crystals will be negative. Positive culture, positive gram stain. If it's staph, it's going to show up positive right away. But if you have something like gonorrhea, it might not show up in the gram stain right away, and you have to do something special to diagnose it. So if you think it's gonorrhea, if you got greater than 50,000 cells and there's no staph seen on gram stain, go ahead and grab a nucleic amplification assay test or grow it on a chocolate agar to make sure you're able to culture or identify that gonorrhea is present in the joint. Usually it's staph, usually you see it. And you can imagine I did this because if you've got osteoarthritis on this side and septic arthritis on this side, well, everything in between is going to be inflammatory. So what you'll see is cloudy fluid, not quite as opaque, is going to be greater than 2,000, but less than 50,000 white blood cells, generally in the 10 to 20,000 range. 50% neutrophils, nothing on gram stain or culture, and you might have crystal disease. That is, if you have crystals, it's a crystal disease. It's gout or pseudogout. But you can have an inflammatory disease without crystals, which is basically all of the joint pains we just talked about in this approach. And you'd have to use the clinical setting mixed with serologies. So we're going to close here with serologies, those that are worth memorizing. There's a lot of them, and I would not commit them all to memory. You want to link serology with the disease. And I want you to understand that rheumatology has a lot of cross-reactivity. No one test is for one disease. But if you learn it that way, anything can be anything and it becomes impossible to memorize or keep straight. So for this setting, I want you to learn one antibody to one disease, knowing that it may not necessarily always be true. It's helpful to maintain sanity. The three that are the best ones to know are the ANA, rheumatoid factor, and anti-CCP. These are also the worst tests. These are positive in most inflammation. So these are sensitive tests. If they're negative, the disease is negative. ANA is the gateway antibody. Basically, all inflammatory disorders can have a positive ANA, but what you should learn is ANA, lupus. Rheumatoid factor, rheumatoid arthritis. Anti-CCP, rheumatoid arthritis. Best three to memorize, have to have those down. The next four are worth committing to memory, but are not going to come up all that often. That is, the double-stranded DNA is specific for lupus, also lupus nephritis. Antihistone antibodies, lupus, but drug-induced. And then the next two are kind of annoying because they're both scleroderma. But scleroderma is not one disease. It's actually two diseases. There's the isolated form called CREST, and then there's the systemic form. CREST is associated with anti-centromere antibodies, and systemic sclerosis, systemic scleroderma, is associated with topoisomerase, also called the SCL70. These seven you want to commit to memory because they're worth knowing about on a regular basis. We're going to finish off with, and I'm going to put them in black because you really should only look at these like the day before the test, just so you're like, oh, I remember that. Good thing I looked at that. And don't commit these to memory. And they are the smooth muscle. This is autoimmune hepatitis, Rho and La, Sjogren's, Joe, polymyositis or dermatomyositis, and antimitochondrial antibodies, primary biliary cirrhosis. And there's some others in here like Pianka and Cianca, but let's not go there. All right, so let's review what we talked about. The first was an approach based on timing toxicity, inflammatory or not, a number of joints involved, getting you into a short list that's going to help you make the diagnosis on the wards, and really, this is all you need to consider for the test. A more robust approach is in the intern content. If red, hot, swollen, tender joint, put a needle in it, do the arthrocentesis. Separate the arthrocentesis into normal osteoarthritis, which are essentially the same, versus floridly septic, 50,000 cells, or inflammatory in between. If inflammatory, figure out what the diagnosis is using the history and the serologies, commit the first three to absolute memory, try to get all seven memorized, and then recognize that if you have to get all the questions right, you need to look at a table of serologies right before you take the test. That's approach to joint pain.